Hi, everyone. We're going to give it a few minutes to allow people to finish dialing in, and then we'll get started. Hi, we're going to give it about another minute or so just to make sure that everybody that is joining us is able to dial in. So we'll get started shortly. All right, welcome everybody to the Care Message webinar today on COVID-19 impact on underserved Latinx communities, cultural dexterous care and the digital divide. And our agenda for today, I'll provide a brief introduction to Care Message. We'll talk a little bit about Latinx communities in the United States, and then we'll move on to a presentation by Dr. Gezer Ortega and Dr. Jorge Rodriguez on culturally dexterous care and the digital divide. If you have any questions, there is a Q&A button at the bottom. Please add your questions there, include the name of your health center. And if you have a specific question for one of the panelists, make sure to include their name. We are recording this presentation, and the slides will also be available via email afterwards. And today, we've got three people speaking. Myself, Cecilia Corral, I'm the co-founder and VP of Product here at Care Message. And we've also will be hearing from Dr. Gezer Ortega and Dr. Jorge Rodriguez. And for those of you that may not know Care Message, we are a patient engagement platform for underserved patient populations. Our mission is to leverage technology to help safety net organizations fulfill the essential needs of underserved populations. And over the last 7 years or so, we've really grown to work with over 300 safety net organizations in over 40 different states nationwide, reaching over 6 million patients. And these are patients that receive services at either federally qualified health centers, free clinics, or other community-based organizations that serve underserved populations. This year, we've, as many of you know, have been really seeing a big impact of COVID-19 with underserved communities. And so we've pushed internally to make our product available to organizations that really need to reach these patients at the front lines. And we've been just really honored to be able to partner with a lot of organizations nationwide to send over 10.5 million COVID-related messages out to underserved patient populations. One of our biggest focus as an organization is on measurable clinical outcomes, and a lot of our research and what you'll hear about today is specifically focused on underserved patient populations. We love hearing and learning about what really is impacting patient populations, and something that we have discovered that may not be news to everybody is the fact that COVID-19 is not impacting all patient populations the same, and especially when it comes to income, there's another layer of that, which is race and ethnicity, that is also providing disproportionate outcomes for communities of color. So Project Equity was sort of the care message response to that. Our vision is a world where all people, regardless of income or background, are able to achieve equitable health outcomes. And we really do think care message and better communication can help, but it's definitely not going to solve the systemic inequities that we're seeing. So it's a small portion and part that we play. But we do think that technology, if it's built responsibly, can also be used as a way to level the playing field for communities of color and just overall increasing access for healthcare. So we are going to be focusing today on Latinx communities. We'll talk a little bit later about some of the other communities we'll be focusing on in future webinars. But we wanted to start today with just providing some education and information on Latinx populations. And if this term is new for you, it's a gender neutral term that's inclusive, a little bit more inclusive than using the term Latino or Latina. You may also be familiar with the term Hispanic, Latinx and Hispanic. You know, I did want to mention, you know, being a Latinx or Hispanic, this is an ethnicity and not a race. Latinx and the differentiation between the two, Latinx includes people of Latin American descent who may or may not speak Spanish. So for example, it includes people that come from Brazil, but it excludes Spain. Hispanic includes people who speak and come from Spanish-speaking countries, but may not be based in the Americas. And so that includes Spain, but would exclude Brazil. So oftentimes when you hear, again, people talk about Latinx or Hispanic communities, you'll hear those terms used interchangeably or together, but we wanted to provide some of that information on the difference between the two. And also to the point of, you know, being Latinx, being an ethnicity and not a race. One of the, you know, great things from, you know, coming from a Latinx background is that we come from a variety of racial backgrounds. And so you can find Latinx people that are Afro-Latinos, Asian Latinx, white Latinx. It's really a mix of things. And it does have an impact in how the Latinx community experiences the world, because even within the Latinx community, there are a lot of racial disparities that are based on how Latinx people present themselves to the world. So I did want to, you know, provide that piece of information that it's a complex group because of all these differences in racial backgrounds and where we come from. Which leads me to the point of, you know, what Latinx people look like in the United States. In the South part of the United States, there are a lot of Latinx communities that have been here for centuries. And so in those instances, you know, people say the border crossed us, not the other way around. Something I hear, you know, very often. I grew up in Texas, and it's something that's just a part of the community. You also have, you know, third and fourth generation Americans that, you know, had families that immigrated, you know, long ago. You've got second generation Americans like myself. And my parents came to the US when I was young, but I was born in the United States. And you've got first generation immigrants that are coming to the United States for the first time. So this, you know, provides a variety of ways in which you have to look at that Latinx community, because again, we experience the world in a variety of different ways, based on, you know, how long you've been in the United States, based on, you know, how you grew up, where you grew up. So it's a very, it's a community that comes from a variety of backgrounds. And so it's important to have that context. But one thing that does unify a lot of the Latinx community is the Spanish language. Most people don't know that this actually predates the English language. It's actually second only to Native American languages that were spoken, you know, centuries prior to colonization. And in the US, you know, you've got about 33 million Hispanics that speak English proficiently. And then you've got about, you know, 40+ million people who speak Spanish. So it is the second most spoken language in the United States. It's something really important to be aware of, because the Spanish language also has, again, to my earlier point, very diverse and regional variation. So it's important to just keep that in mind when you're communicating with your patients that come from a Latinx background, to be aware of, these variations and differences. It is estimated that by 2050, the US will have 138 million Spanish speakers. So it's a population that does keep growing. And going a little bit into the healthcare piece of this, there are a lot of things that we understand about, and in this case, I'm using the term Hispanic because that's what's used mostly in literature for this patient population and this population in general. But we do see some disparities. For example, 68.7% of Hispanics versus 92.9% of non-Hispanic whites have a high school diploma. And then that has an impact from a healthcare perspective, because although we make up 16% of the population, we only make up 7% of doctors, 6% of dentists, and 5% of nurses. We do, however, are overrepresented when it comes to work within service occupations. And I think this is where we'll get into the kind of COVID specific aspect of this, but this is why, Hispanics and other communities of color are overrepresented in industries that are today considered essential workers and are really being exposed to COVID-19 at a higher rate. Hispanics also have the highest uninsured rate of any racial or ethnic group, and we have higher rates of obesity. And again, even as I mentioned, there's variations within the Hispanic or Latinx community, where we even have other sub-aspects of disproportionality, with Puerto Ricans suffering disproportionately from asthma versus Mexican Americans who suffer from diabetes at a higher rate. And to my earlier point around, when a family has come to the United States, or those that were in the United States before, there is something that you may or may not know about, which is the Hispanic health paradox, which is, immigrants, first-time immigrants to the United States tend to have better health outcomes, but within a few generations, we start to see those outcomes deteriorate. So it's something that is, still being studied in terms of understanding the long-term effects of that, and how that's presenting itself with Hispanic populations across the United States. And so when it comes to COVID-19, as I mentioned at the beginning of our presentation, our focus at CareMessage is on working primarily with FQHCs and free clinics that are serving underserved patient populations. We consider these to be really the backbone of our healthcare system throughout the United States, and it's really our avenue for reaching underserved patient populations. Some things for you to think about if you're joining this webinar and you work at an FQHC or free clinic, really providing those resources in Spanish is very critical. As I mentioned, we've got over 40 million Spanish speakers across the United States. And so try to find a way to use neutral Spanish, or just tailor it further if you do know that you maybe have a Spanish speaking population that is maybe comes from Mexican descent versus Puerto Rican or Dominican. So it's important to take those, again, variations into consideration, but having those resources available if a patient does prefer to be communicated with in Spanish. And it's something that's also really important for the technologies you decide to use. We're finding a lot of you are probably starting to use telehealth for the first time, probably something you want to check for in terms of whether that technology or service is available in Spanish, to make sure that you're not leading to any barriers for your Spanish speaking population to be able to access services that you're providing. In addition to that, I think capturing race and ethnicity data correctly is also really important at this time. Infection and death rates are probably being undercounted in communities of color. And this is something that we've seen some of our existing users of CareMessage even use CareMessage to capture some of that information and correct their records so that they are capturing this data correctly in terms of how they're tracking infection rates amongst their patient population. And then the last thing is for those of you that may have patients that are immigrants and potentially undocumented. We've got millions of undocumented people in this country, or those that live in a mixed status household. It's something that I think our undocumented patients were living in some sort of fear before COVID-19. But now with COVID-19, it's exacerbating a lot of those concerns that they might have had in terms of just being able to access healthcare. So it's just really important that those lines of communication are there, because a lot of our healthcare providers just have that established trust to be able to reach out to these patient populations and ensure that they're the care that they need, and potentially if you can become aware of resources that might be beneficial for them, that information makes its way to those undocumented patients that have been excluded from a lot of the benefits that documented people are able to access when it comes to like federal stimulus money and other access to resources. So I'm going to hand it off now to Dr. Gesser Ortega and Dr. Jorge Rodriguez. I will let them introduce themselves and we'll go from here.
Yeah, this is Jorge taking over. Thank you so much for that wonderful introduction, and thank you to the Care Message team for having Dr. Ortega and myself on this afternoon, and thank you everyone for taking time out of your day to join us and discuss this important topic. Dr. Ortega and I will be chatting with you about delivering culturally Dexterous care in the digital divide. I'm starting off. My name is Jorge Rodriguez. I'm a hospitalist and a technology equity researcher in the Department of General Internal Medicine at Brigham and Women's Hospital. And Dr. Gesser will give his intro once he takes over in the latter half of this presentation. Next slide. So to start, we have no disclosures to report. Next slide. So the sort of overall approach to this talk here today is really sort of one, trying to highlight some of the policy changes that are quickly changing the digital health and virtual care environment in our healthcare system. It's sort of the first part that sort of lays the groundwork about why we're talking about this today and why there's a little bit more of an urgency. Two, I'll talk about highlighting sort of in the pre-COVID era where we're starting from, and really seeking to highlight the fact that we have work to be done if we're really shifting towards sort of a digital health and virtual care future in healthcare delivery. And then Dr. Ortega will continue with some potential solutions and next steps in how to provide culturally Dexterous care in digital health. So I'll start off here. Next slide. So to start, as a result of the COVID-19 pandemic, there were kind of key things that happened. One, there was a call for stay at home, recommendations for social distancing, and a real concern for hospital capacity. So it was this general shift to move healthcare away from like the healthcare clinics and healthcare setting, and really to move it remote. And so that was, really kind of brought on by kind of a public health need, and then further supported by policy changes delivered by the Center for Medicare and Medicaid Services. And they made two important changes. One is the change in reimbursement. Obviously, kind of the financial aspect of this is key. And the main change here is that they created parity, or they created similar reimbursements, at least for Medicare, amongst video, audio, and in-person visits, which is critical in sort of the ability for clinicians to deliver care. So that was the one sort of big change that happened during this pandemic. And two, they changed the kind of privacy laws. It used to be that you had to have a specific HIPAA-compliant vendor to be able to deliver telehealth services to your patients. But during this COVID-19 pandemic, in order to kind of help stimulate the use of telehealth services, they relaxed it a little bit. So that's why you've seen the rise of things like Zoom or WhatsApp or FaceTime or whatever sort of video platform you could use. There's like a Doximity platform that's available as well. And that also sort of allowed that support. And then the FCC on its hand, kind of from a technical side, realized there's a lot of clinics, and maybe a lot of the folks on this call really didn't have the telehealth infrastructure built up, sort of and ready to deploy compared to other centers. And so they've invested $200 million as part of the CARES Act to expand telehealth services. And as of, I checked this about a week ago or so, and they've dispersed already $13.7 million. You're still actively accepting applications for this program, and kind of looking through who's getting a lot of these funds. It's a lot of FQHCs and a lot of folks who, at least in their description of what their goals are, is really focused on underserved populations, including a lot of Latinx populations. So there's sort of a lot of funds going. So there's the fund component, there's the policy component, And we haven't just seen this this change at sort of the high, sort of high policy level. It's really happened on the ground. Next slide. And this is work by Dr. Malhotra and the rest of his team here, and they show sort of a clear shift where, prior to their shift to, there we go. Prior to their shift to virtual care, you see that in the blue, they were doing a lot of office visits. And then once they decided to shift to telehealth, even though volumes overall dropped, there was this quick shift of just delivering everything over virtual care. So essentially, saying that at least at their health center, it wasn't just sort of this idea that we should, this is a potential thing we should do. This really happened in real time, and it'll be interesting in the Q&A to hear from folks about what their experiences has been. I think their center had a more kind of robust telehealth infrastructure and was able to deliver it fairly, was able to make that shift fairly quickly. Next slide. And so as we kind of, take a step back and say like, all right, like how can digital health and how can virtual care really help address some of these questions? It really comes to the point of like, are we creating more disparities by making this like quick shift towards virtual care? And one kind of framework or one idea I always like to step back to and think about is by Dr. Lopez over at UCSF, who really highlights the fact that when you're implementing or when you're kind of taking on a new HIT tool, you really have to, and you want to eliminate disparities, you really have to think of two things. One is that you have to design from the get-go with the idea that you're going to identify and eliminate some sort of disparity from the start. It really can't be sort of an afterthought. And I think a lot of the folks on this call will probably reflect on like some of the technology tools we've developed for patients so far. The disparities or equity angles have been a little bit of an afterthought, and I'll kind of jump into that a little bit more later in the talk. And then two, you really have to tailor it to the needs of underserved populations. And even though these kind of two kind of points are really essential, part of my pitch to you, my thought for you, and I think a lot of folks on this call will agree, is that we've essentially not done a very good job of following these thus far. And Dr. Ortega will kind of lead us through how we're gonna hopefully arrive at some solutions going forward. So next slide. So the next few slides are really going to focus on, I'll admit they're a little bit of kind of like, kind of a little bit of downer slides, but it sort of leads to a hopeful outcome later on. It's really highlighting a few of the different digital divides, areas where we're really not engaging our Latinx and our underserved populations very well using digital health tools. Next slide. Great. So digital health is a very broad term, but at least in this context, I'll sort of highlight three key tools here. One, it's patient portals. I always highlight patient portals because they're the primary patient-facing tool that's delivered by most healthcare systems and most clinic. A little bit of their history. They've been around since like the late 1990s, but they really kind of got their expansion in like 2009 after the HITECH Act. There were so both policy and financial incentives that drove healthcare systems to pick up patient portals, and they're widely available now. As many of you know, they allow patients to do all sorts of things, including request refills, request appointments, review their medical record, message with their care teams. They're increasingly being used for research recruitment, as well as allowing patients to submit their own data either through through their phones or wearables, or through patient-reported outcomes. So that's one set of tools. The other thing I talk about will be mobile health apps. Obviously play a big role. This is more of like an industry kind of dominated space with more than 350,000 health apps out there. It's a little bit of a wild west, but even in that space, we'll sort of highlight some disparities as well. And finally, of course, the kind of main topic that's on everyone's mind nowadays is around telehealth. And so I'll highlight how telehealth looked before we entered this COVID space, and why there's some concern around sort of disparities along that space. Next slide. So for patient portals, so this is sort of national data from like 2016 or so. So patient portals is one of those instances where we built these tools, but patients didn't necessarily follow or didn't necessarily engage. So this number is probably on the lower end for now. Now you're probably looking at greater than 95% of clinics and healthcare systems offering some form of a way to access your information online, but unfortunately only about a third of the patients were actually able to, or actually decided to actually look at their information. And if we dive a little bit deeper into that 31% number, and we say like, all right, so there are 31% of patients using, accessing these tools. What do those patients look like? Next slide. And unfortunately, we see some significant disparities in access across all sort of expected demographics, with Latinx and African American patients being less likely to use patient portals, those of lower income, lower education also being less likely to use the patient portals, older patients also less access to patient portals, and then limited English proficient populations, which I think is particularly notable for Latinx populations, since they have a large Spanish-speaking populations being less likely to use the portal. And sort of, I'm sure you guys have experienced, we can go into, there's a lot of sort of challenges around what vendors are providing in terms of language and translation and what it takes to actually make that real at the patient portal level. And then folks with disabilities and folks living in rural areas also have less access to the patient portal. And I always like to take a pause here and take a look at this slide just for a second. And so if we can imagine, looking at these demographics, and then we think about sort of our chronic diseases that we manage, the diabetes, cardiovascular disease, hyperlipidemia, and we think about who are the patients that have the worst outcomes, my suspicion is that these demographics will look strikingly similar. But the whole pitch of patient portals and of technology has been that we'll have sort of this newfound access to these patients and we'll address all those issues. But to this point, we really have not made that change, because the same patients that are having the worst health outcomes also seem to have less access to this technology. And that's sort of been one of the big challenges with patient portals and with kind of patient-facing technology overall. Next slide. And if we move into the mobile health app space, it's sort of a similar story. This is a study by Dr. Singh and his group where they sort of went through and looked at a bunch of different health apps and basically found that a lot of the apps that were available in the marketplace. So if you think about a lot of Latinx patients going out, and I always think about like my mom or my aunts going out and trying to find a health app for either their hypertension or their diabetes, they would likely find that a lot of the apps that are developed are not really made for them. And that's for literacy reasons, for kind of technology literacy reasons that we'll get into. So they're not really kind of, targeted at these populations, and really is a missed opportunity. And then next slide. And then talking about telehealth, this is telehealth, was what before the COVID-19, telehealth was on the rise. There was sort of an increase in video visits on this study from so that they more than tripled from 2013 to December 2016. So it was already on the rise, but even in as it was rising, we were already seeing signs of disparities arising with patients on Medicaid, patients who were low income and rural populations being less likely to use these telehealth tools. We were already seeing these gaps. And then next slide. And then in the post-COVID-19 era, this is really great and timely work that just came out last week from Dr. Nuri and Dr. Kung, Dr. Lyles, and Dr. Collerner over at UCSF, where they essentially showed that in terms of just the overall kind of visits, like who's kind of getting care at these clinics, they found that after there was this shift towards virtual care, toward telemedicine, there was a big drop across the board here, and highlighting here for us today that, as you can see in the blue compared to the orange for the Latinx populations, there was this drop in terms of like who was accessing care, who was having visits, and we see this shift, and a lot of that shift I think is related to that lack of access to technology and some of the challenges that comes with these platforms. So it's something that we're seeing in real time, and this is really sort of striking and timely work, and part of the reason we decided to kind of Dr. Ortega and I decided to take this on and think about how do we address these gaps, and how do we move forward. Next slide. So if we start thinking about, take a step back and think about, okay, like we've, like great Dr. Rodriguez, you've highlighted these points. So like, what's going on, what's driving this, or what are the kind of the issues here? There's a bunch of different issues that come up, but I always like to take a look at least three kind of reasons why this is happening. One, I think, is it's very basic things like, having access to a device, having access to the internet, and being able to use those tools that you now have in hand. Next slide. So in terms of broadband internet access, we know that at least 21 million people in the US lack broadband internet access. And this is from FCC data, and this is sort of probably a significant underestimate. When we've looked at other studies have reported as many as 42 million, and there's another study that sort of lists an even higher. So we suspect that this is likely an underestimate of who is actually lacking broadband access. And I'd like to make sort of 2 points here. One, we specifically say, broadband internet access, because, unfortunately, all internet access is not created equal, and having access to broadband internet access versus dial-up internet access creates like a very kind of vastly different online experience, and really sort of limits the ability. If we're thinking about telehealth, especially video telehealth, it requires a certain amount of internet speed to be able to do that. So you really sort of have to focus on not only like, do you have internet access, but rather like what's your speed? Like, what are the details in there to really make sure that patients have appropriate access? And the second point I like to make here is really around, if we think back to when I was talking about patient portals and the demographics of patients who are lacking access, we can essentially take those same demographics and apply them here. It's those same sort of, including our Latinx populations, those who are lacking internet access. Next slide. And this has, significant, this is not just sort of like, oh, they're not able to kind of go online and, stream movies or something. This has sort of significant implications for health, really. And so there's sort of 2 points here. One, that, there's work showing that patients living in low broadband access area were about 11% less likely to use the patient portals. And then looking at telehealth specifically, in those rural areas that lack broadband access, those same areas also had lower telehealth use. And those were the same areas that had decreased access to primary care physicians and psychiatrists. So if you take a step back and think about that, you say, well, a lot of the pitch of telehealth is to expand access amongst many populations, Latinx populations, rural populations. But if they have less access to broadband and less access to telehealth, we're really not going to be able to, to kind of achieve our very noble goals. And so we really have to kind of get at the point of addressing some of these, kind of digital divide along broadband access. Next slide. And then, having internet access is one thing, having a device to be able to use it on is another thing. I think that even though, at least for smartphones specifically, 81% of the US population has a smartphone, you still see some discrepancies across age, with older populations having lower rates of smartphone use, education with folks with less than a high school diploma having lower rates of smartphone use. Next slide. And similarly across income, and notably across living in a rural location as well. So sort of a device divide here as well. Next slide. And so the last part of this is really, so you have your internet access, you have your device in hand, you're ready to go, ready to like use a patient portal or engage with your care team through a telehealth tool. So are you able to do that? And the answer might be surprising here. I think, but my sense would be probably not for some patients, and that relates to towards technology literacy. I know so I think Cecilia in her part of the talk mentioned about sort of the challenges of literacy in some of our Latinx populations, and sort of there's almost a direct correlate here in terms of being able to use these tools and really engage with the healthcare system. So this is a really great work by Dr. Sarkar and their team over at UCSF, where they essentially took a series of 11 health apps that you find on the app stores, and they gave it to 26 patients in an underserved community, largely, or a good proportion of them were Latinx. And they said, all right, can you complete these various tasks to see how they were able to perform? And they were only able to complete about half the tasks. So if you can imagine, if you can only complete about half your health tasks, that's not really going to lead to the outcomes, the clinical outcomes that we're looking for, or the ability to increase access or decrease utilization, or all these things that we all strive for. So it really kind of creates this, this kind of added gap. And so next slide. And so I don't, I think I present these slides not to kind of, make us all feel a little bit sad about, the current state pre-COVID, but I present these slides really to highlight the fact that, technology access really is becoming a social determinant of health. And I think that the COVID pandemic has only pushed us even further as virtual care and telehealth have really kind of taken off. And so it really pushes us to think about, next slide, how do we provide that culturally dexterous care in digital health and ensure that these divides that I've highlighted don't persist and kind of exacerbate existing disparities. And so with that, I'll pass it off to Dr. Ortega.
Thank you, Dr. Rodriguez. This is Dr. Gez Ortega. I'm faculty at the Center for Surgery and Public Health at Brigham and Women's Hospital, and I'm glad to talk to you today and just help to try to figure out how do we provide culturally dexterous care in the digital health. And thank you, Care Message, for allowing Dr. Rodriguez and I the platform to have this conversation today. Next slide. And so I'll begin with discussing equitable healthcare. One of my mentors, Dr. Adel Haider, he always mentions equality being the cornerstone of medicine, and I always kind of counter him with equity being the true cornerstone of medicine. And the Robert Wood Johnson Foundation has this great cartoon here kind of demonstrating the differences between equality and equity and promoting in their Promote Health Equity campaign. And so for us, and when we talk about equity, we're really focusing on addressing the social determinants of health, social risk factors, and social needs of patients and communities to eliminate disparities and provide equitable access to and outcomes of high quality healthcare. And so that is what we define as providing like equitable healthcare. Next slide. And so with that said, we wanted to kind of shift the conversation from cultural competency over to cultural dexterity. And some have even used it as synonymous with like cultural sensitivity, but we like the term dexterity because it kind of refers to a skill, and it's the dynamic application of cultural knowledge, emotional intelligence, and interpersonal skills that is adapted to provide patient-centered care to all patients. And at the core of cultural dexterity are these of providing cross-cultural care are these three tenets of curiosity, empathy, and respect. Next slide. And so, as Dr. Rodriguez mentioned, one of the focuses of this part of the talk is going to be on kind of like what we can do moving forward and what some recommendations are, and kind of taking together some of the practices that we've seen. And so already we know that there are like governmental level policy implications. And so regarding reimbursements, one of the solutions could be to expand beyond Medicare to Medicaid and commercial insurers to ensure that all patients are covered for telemedicine and virtual care. The coverage should include undocumented, uninsured patients, as we know that there are going to be a rise in newly unemployed patients in the current economic crisis and the pandemic that we're in, but also the gig economy jobs that we're seeing that continue to grow. And as audio and video services should be reimbursed. Currently, right now, they vary on reimbursement, but also the state level policy variations also contribute to the differences that we see in how patients access virtual care and telemedicine and telehealth. And Dr. Rodriguez alluded to this earlier, but broadband internet access is important. And so there've been, as he mentioned earlier, the FCC continues to expand funding and subsidies to support both healthcare systems and patients in establishing adequate technology. And one of these examples is Lifeline, and there's a Lifeline link at the bottom of this page, but also expanding broadband infrastructure to support rural populations, as there are a demographic that usually does not have the broadband access that is afforded in some of the other areas, but in opportunities to exist and to invest in community organizations such as libraries, and which is a hub for people to get broadband access, to continue to provide another venue for internet access and technology literacy support. Next slide. And so for the hospital level responses, we definitely believe that it should start with gathering individual information on technology access, literacy, and privacy. I mean, that's critical to kind of get an assessment of where we are with the current problem and where we need to go next. once we have an assessment of those things, then mobilizing resources to improve access for patients who may not have it, and information technology related training and education, because our providers also need to be trained on what's currently out there, but also subsidizing access to internet options and access to physical hardware with video conferencing or audio capability. And so many of the patients' needs can be met by partnering with local organizations that may offer technology training courses. There's also access to subsidized services. There are programs where they're donated mobile phones and other hardware, and a special note on just health monitoring wearables and devices. A lot of that has already started happening during the COVID-19 pandemic, where healthcare facilities are providing patients with mild or asymptomatic with just monitoring devices to keep track of them while they quarantine at home. Next slide. And so creating this versatile digital health, right? One of the things that the AHA has this digital pulse in which hospitals and other healthcare centers can use to access or to assess their digital health capabilities and access potential solutions and improvements. And again, that website is at the bottom of this page. And we realize that if it comes to digital health, telemedicine, and virtual care, that there's not a one-size-fits-all solution. We need to have flexibility to customize our technology to meet the needs of our patients. And more importantly, privacy concerns. Whether we use audio messaging platforms that could provide them with safer access to care. And with Care Message, one of the benefits of using text messaging is like, one may notice that there may be patients in which you can't do video conferencing. And we've already noticed that there are patients who don't have privacy at home and are taking their video calls from their car or from a bathroom or a restroom or just a place where they have some sort of privacy. But in situations, potentially if there's like intimate partner violence or other circumstances which are sensitive that don't allow for video or audio messaging, text messaging may be the most suitable route. And so making sure that we have the flexibility to provide our patients with all those options is important. And then remote monitoring technology, as I alluded to a little bit earlier, but having the objective health information like vital signs and pulse oximetry in patients may not be necessarily available for audio video chat, but if it is, helps tremendously in providing the optimal care for our patients. Next slide. And as was mentioned earlier, addressing social determinants of health. I think that at the institutional level, we need to make sure that we're screening and we're addressing the social determinants of health, and more importantly, the social risk factors and needs, right? So where there's housing and food insecurity, access to affordable childcare, considering catastrophic health expenditures, which probably will get even more as the pandemic continues to evolve in this, and then also the financial crises that our patients may be undergoing that doesn't allow them to fully engage in their health. And then institutional dashboards so that we can guide screening for and support for the social determinants of health issues are needed to be developed and disseminated in a culturally dexterous manner. Next slide. And so incorporated interpreter services, especially as we think about our Latinx community, adopting platforms that can incorporate a third-party interpreter is vital to providing culturally dexterous care to patients with limited English proficiency. Even providing COVID-19 related instructions in other languages is going to be critical. Communication with families, using technology to communicate with families during the current pandemic as patients are isolated and can't directly communicate with their loved ones. And then the implications beyond, right? We have to understand that some of this technology and the interventions that we have that are not only going to help our COVID-19 patients and those indirectly impacted by it, but also the rest of our society. Next slide. And we also have to monitor equity, right? A lot of hospital systems have increasingly recognized the importance of diversity, inclusion, and equity. And we know that patient portals are underutilized by underserved populations. And so as virtual care becomes more widespread, these equity issues have the potential to be amplified. as was already alluded to earlier. And so one of the suggestions that we have is to make sure that we create a digital health equity task force, so that in creating this, we ensure that new digital health tools actively engage underserved patients in a culturally dexterous way, but also that we develop and gather equity metrics to monitor utilization and access among vulnerable populations. And so as we are thinking about the next phase and how do we do this, having this equity task force be part of the digital task force and the digital operations of the hospitals and institutions that we work at and the healthcare centers is critical to the next phase as we move forward to try to mitigate some of the disparities that we see. Next slide. And at the provider level, having the dexterity to kind of make sure that we can navigate these nuances through virtual care is important. Standardizing televisits as the primary form of care for all patients is important, while also adapting the specific type of digital health to meet each patient's individual needs. The patient-provider relationships will require the providers to dedicate additional time to bridging the emotional gap created by technology. But also we have to be mindful that this virtual care and having access to patients now provides us a unique window into their lives that we were not normally privy to. And so being sensitive to that and to the needs of our patients. Expanding digital health to not only include physicians, but pharmacists, social workers, and other members of the healthcare team so that we can assist in providing better evaluations and engagement with the social determinants of health for our patients, because we understand that this goes beyond just the patient-provider relationship. And then sharing resources, being able to provide online resources for social services or referrals through video, audio, or text messaging is important because then it could potentially link patients immediately to these resources. And some of the resources that we mentioned here at the bottom, you see this link, but UCSF, the Center for Vulnerable Populations, they have an excellent resource for telehealth at safety net settings, which we want to make sure that people kind of visit when they have the opportunity to do so. Next slide. So in conclusion, the COVID-19 pandemic has pushed health systems all around the world to develop innovative ways to address ongoing challenges and to figure out ways to rapidly deploy such solutions, such as digital health. And so as we continue to adapt to provide our patients with the high quality care they deserve, with a firm focus on achieving and maintaining health equity, and the models developed today have the potential to transform the future of healthcare, particularly as virtual care becomes an integral part or integral component of future care models, and making policies that incent this is pivotal. And so if cultural dexterity is made an integral part of virtual care now, it will then ensure that we can benefit from digital health. And so next slide. And so with that, I, Dr. Ortega and Dr. Rodriguez, will thank you for the opportunity to share our thoughts and our slides with you today. And we'll move on, but we wanted to acknowledge our mentors and mentees also that have contributed to our talk and have helped us in preparing this lecture.
Thank you so much, Dr. Ortega and Dr. Rodriguez. I'm just going to close up with some last thoughts. As we've been talking about, the core of the care message technology is on the text messaging piece. And whether you're using care message or some other system, we want to really encourage the continuation of using text messaging. It's a very accessible digital health tool that can enable you to reach as many patients as possible. I think it's really important during this time that that information is coming from a trusted source. And so I think for those, healthcare organizations on this call, just a quick example of that for Latinx communities would be to clarify, for example, that maybe citizenship is not necessary for COVID testing or treatment. So again, getting that information from a trusted source can go a really long way for our underserved communities to get the information and the access that they need during this time. Texting is a very scalable way to both disseminate information and collect data. So it's something that we've seen a lot of our customers use. And so I wanted to highlight just a few use cases of what we've seen with some healthcare organizations that Care Message works with. The first one on just gathering insights on patient needs. We did have an organization that asked their patients, what resources do you think the Hispanic community and the immigrant community needs during COVID-19. And we saw a great number of responses coming back from patients, talking about housing or rent assistance, as well as needing access to food and help with other financial resources. In terms of disseminating information, Informed Immigrant is a website that has also done a lot of work in terms of centralizing resources specifically for immigrant communities. So there is a sample message that the care message team has also developed to help get information from that website out to patient populations that might be relevant and helpful for them. And then the last thing is making patients aware of other resources in your community. This last one was sent out by one of our free clinics that was just letting their patients know about resources and phone lines that they could call that had interpretation services available in Spanish. And so again, making that information available in Spanish is really critical. And if you happen to need some help with getting information created in Spanish, don't hesitate to reach out to the care message team. We're happy to help. And so the last thing is just what we've, kind of offered in response to COVID-19. The care message product is available for free for any, community health center, free clinic, FQHC that needs to get information out to their patients and wants to start using text messaging. You can visit the care message website and sign up. It's free, for at least 60 days. We don't know how long this pandemic is going to last. And so we will likely be extending that for our organizations. There's no long-term obligation to pay for the use of the product. We've had about 100 organizations sign up in the last 2 months, covering almost 1.5 million patients. And so it's an opportunity that's available to you. And we also do have some free care message resources available. We have a texting library that we've created. You can use those text messages either on the care message system, or if you have another system that can send text messages out, it's available in both English and Spanish. And we also have created a library of videos that are available on our YouTube channel, just to help explain to patients what telehealth is, how to prepare for a telehealth appointment. And then we also have some explainer videos in English and Spanish for how to use two of the top telehealth tools that we've seen our clinics use, which were Zoom and Doxy, Doxy.me. And with that, we'll open it up to Q&A. And I believe Christine from the care message team will help us moderate here.
Thank you, Cecilia. Hi, everyone. My name is Christine Chang, and I'm the Strategic Partnerships Manager here at Care Message. Please go ahead and submit your questions via the chat or the Q&A feature. It looks like we have a few already, so we'll begin there. The first question is, what screening questions or script do you think is helpful when clinics are reaching out to set up telemedicine appointments? Any helpful techniques, and who should do the screening and prep, and is there any reimbursement? A pretty broad question. So Cecilia, if you don't mind sharing perhaps a little bit about our library, and then Dr. Ortega and Dr. Rodriguez, if you have any follow-up thoughts there, please do feel to chime in after.
Yeah, I'll share very quickly from a care message side. We've had some of our clinics use a text message survey to ask a patient, do you have access to one of the following? A phone call, B, a video call on my phone, C, video call on my computer. So that might be a quick, easy way to get that information from your patients in terms of what technologies they have access to, and then decide from there kind of how to approach that transition into telehealth, and deciding whether you're going to move to a audio call or video, or potentially a mix of those two. But that's what we've seen on the care message end. I'm not sure if Dr. Ortega or Rodriguez have any other thoughts.
Yeah, I think I'd say that, when Gezer and I have talked about this and sort of this idea of kind of screening, or at times I'd imagine that at the point of like registration, there's a lot of questions we ask at the registration in terms of when you're coming in for your visit, when you're coming in for, an inpatient stay. There's a lot of questions at registration asked, and we thought this sort of was a natural place for it to live, because I think it sets up a sort of a key information source that is then fed into the EHR. And so you're able to kind of, from a clinical side, be able to access that at different points. So when you're saying like, oh, do you want to follow up with a virtual care, appointment, you'll be able to see that information up front. I think the question of prep is a little bit more challenging in terms of who's doing that preparation, who's providing the training. And I think that's where we've seen the role of kind of community partnerships, either with community centers or libraries who for a long time have been sort of in the space of kind of technology training as kind of key allies to get this done. And I think it's either invest, and I think from a reimbursement standpoint, it's either direct investment from healthcare settings, or there's I know there's some waiver programs through like Medicaid or Medicare that support kind of social deterrents of health, which could be used to kind of drive this a bit more. But I think there's definitely work to be done in terms of establishing clear workflows for that.
Yeah, and
Great.
yeah, I agree with Jorge with all those.
A question for Dr. Ortega from Yvonne. Any recommendation of a free platform, self-friendly for patients who don't have access to a computer?
Yeah, I mean, there are a couple of options out there. And what I was going to do was, I saw that question came up on the Q&A section. Just in essence of time, would provide a list of resources, and Jorge and I can we've talked a little bit about a few of them, so maybe we can just provide that and then share it with Care Message, but also share with those who are the participants on the call.
Great, thank you. We have another question from Dana. Do you have guidance on FCC regulations for texting patients assigned to us but have not yet been seen? And can we send an initial text without a specific opt-in? Cecilia, if you could share from the Care Message side, that would be great.
Yeah, so this is actually a very big use case for a lot of our health centers. It is, and we can send out, through the contracting process, we can share information around sort of patient consent and what is considered an explicit consent when the patient has provided that phone number to be contacted when it comes to healthcare services. I know they've provided it to the health plan, which then provides it to the provider, so that does somewhat carry over. And so what a lot of our clinics have done with those specific assigned patients is they send them an initial text message letting them know, hey, we are Clinic X, you've been assigned to our health center. We'd love to, help you meet whatever healthcare needs you have during this time. And then they'll give them, different options, whether it's to text yes if you want to be contacted to schedule your initial appointment, or call us, or when can we call you to get you set up with our clinic. So it is something that, a large number of our customers do pretty regularly. And we can provide, some of the background information, legal information around the consent piece of that.
Great, thank you, Cecilia. We have about 3 minutes left and are happy to remain on the line for questions. And Cecilia, if you don't mind sharing the next slide while we wait for additional questions to be submitted, did want to share that our Project Equity webinar series continues into next week, in which we will focus on the American Indian and Native Alaskan communities. After today's webinar, you'll receive an email follow-up from our team with the recording of this session, as well as the registration link for next week's webinar. A question from Karen on how to stay in touch and how we can follow the doctors on their efforts. Wonderful. Their contact information is right there.
I'd say that both guys and I really, I know we have a lot of folks from FQHCs on the call, so it'd be sort of really are impressed and inspired by a lot of your work, and definitely look forward to please reach out with any solutions that you've had. We sort of think about this at a certain level, but I know that everyone comes up with amazing solutions, and we're all trying to work on addressing this issue together, and really kind of all striving for the cause here all together.
Absolutely. Then with that, want to thank everyone again for joining us in today's webinar. Please don't hesitate to reach out with any questions that you might have, and we look forward to seeing you at the next.
Thank you.